Recording in progress.
Good morning, good afternoon, good evening, good night, whatever time that may be. Cheers with a Diet Coke. Change of plans. We're going to have week 4, lecture 1.5. We're going to go ahead and finish those last 10 slides talking about beta blockers. I think it's important that we keep that on the same test. So let's just go ahead and jump into it. Let's get it done and get you all ready for test 1. All right, here we go. Very important high yield information.
Starting screen share.
We have started screen share. I don't know if you all can hear that robotic voice. I find it irritating, but it's kind of cool. Okay, here we go. We're going to talk, when we talk about adrenergic antagonist or beta blockers or alpha blockers. You won't use alpha blockers as much in clinical medicine. You will use beta blockers often, but we use these for blood pressure and we use them for heart rate. A lot of times with the beta blockers, we'll use for heart rate if someone has supraventricular tachycardia or they have AFib with the rapid ventricular response. We will use that to slow down the heart rate. We certainly use beta blockers. That's one. Remember the 4 pillars when we talk about congestive heart failure? Beta blocker is one of those. Specifically, we like to use a drug called Coreg or carvedilol, I believe that's how you say it, or a drug called metoprolol, so specifically the succinate salt. There's a succinate salt and a tartrate salt. The succinate salt is the 24-hour or the Toprol XL form of metoprolol. But again, we use that. Remember, the sympathetic nervous system, fight or flight, wants to keep you alive. It's sending out norepinephrine, and that's causing your heart, it's innervating your heart, right? And that's causing that left ventricle to beat faster and stronger. But in congestive heart failure, while in an acute decompensated state, that's your friend. We will actually stop the beta blocker when you're in decompensated heart failure and restart it once we unload that left ventricle. But again, you get that ventricular remodeling from that constant barrage from the sympathetic nervous system. So your ventricle, you can see from the inside, gets smaller. There's less volume in addition to expansion. So, but it's trying to save you. You also know that norepinephrine binds to beta-1 receptors on what? In the kidney, that juxtaglomerular apparatus. And that leads to what? That leads to renin release, and that leads to going down through that renin, angiotensin, aldosterone system, that whole schematic, that leads to increased aldosterone and sodium and water retention. So that's going to expand your preload for sure. So now that left ventricle has more to try to pump out, and already can't do a job efficiently with what it has. And you can see how this can continue to go on. And then from a urological perspective, we certainly use alpha blockers in benign prostatic hypertrophy. So we'll talk about that as well a little bit. But we're going to cover all that in more detailed lectures. So your alpha blockers or your alpha adrenergic blocking agents, these can block both alpha 1 and 2. And we've discussed this. Alpha 1, when you innervate alpha 1 in the periphery, what does it do? It causes vasoconstriction, right? So it kind of closes those, increases your blood pressure, right? Kind of go from here to here. If we block it, what's it going to do? It's going to dilate it. So it blocks and reduces sympathetic tone on the blood vessels. And this is going to what? Decrease your peripheral vascular resistance and subsequently lower your blood pressure. Now, if you have a very, not an insidious, but a rapid onset on decreasing blood pressure, you can get a reflex in heart rate because your body, again, your blood pressure drops and your body senses you're not perfusing, you're not getting enough oxygen to whatever. So in that case, what's the best way to compensate? It's just like when you go jogging. What does your body do? Your heart rate goes up, and that's because your body senses a lack of perfusion. So whatever may be the cause of that, that's why you get reflex tachycardia. So we do have our selective alpha-2 blockers, which have limited clinical utility in our practice. We won't really go into that. but our focus is going to be blocking alpha-1. But we talked about those that are agonists at alpha-1, right? Phenylephrine being pure. We talked about norepinephrine. We talked about epinephrine. We talked about dopamine. We talked about midodrine. Remember all of those agents we talked about to try to bring your blood pressure up. So it stands to reason if you do just the opposite of these, you're going to lower blood pressure, right? So remember, be smart when you study the autonomic nervous system. So our alpha-1 selective blockers, these are going to be drugs. They're all going to end in zosyn. So prazosin, terazosin, doxazosin, these are all used to manage hypertension. And we'll use them to prevent urinary retention as well in men with BPH. We talked about that. You'll see it some, not as much. Why? Because we now have more selective alpha blockers that don't have the orthostasis and the reflex tachycardia and a lot of the side effects we see with these medications we talked about here. These drugs, when it comes to blood pressure management, they're going to be third line, maybe even fourth line. We just have better options now, and we don't really use them because of their side effects. It doesn't mean you cannot use them. Every now and again, every blue moon, you'll see an order come through for them, and usually it's a gentleman who does have benign prostatic hypertrophy, and he does have high blood pressure, and he's been on it for ages, and it's just not worth the change. Maybe the patient didn't want to change, so that's something to keep in mind. But these would be your novel drugs. Your alpha-2 blockers, yohimbine is going to be your prototypical drug. That's used to treat male impotence and sexual dysfunction caused by antidepressants. Do we still use this drug? No, I haven't. I've back when I first got out of school in the mid-90s, you would see prescriptions every now and again for yohimbine. I don't think I've seen a prescription for yohimbine 20 plus years. I can't even think back when I saw one. I know I've seen it before because I've seen the bottle. But it has a narrow therapeutic index, and it's just not something we use. So is it something you need to know? I think you need to know that yohimbine's an alpha-2 blocker that could be, but we have, when you talk about erectile dysfunction and impotence with all these new Viagra type drugs that we have much safer options to treat that anyway. The injections of prostaglandins at the base of the penis, no one wants to do that. So who would want to even take a drug, even in this case, with the side effects that come with it? So we're not going to focus on it. Okay, beta blockers. We're going to have a more detailed discussion later when we talk about congestive heart failure. But you're going to have two flavors. You're going to have non-selective and selective, or the selectives are cardio-selective beta blockers. The non-selectives are just what you would think. They block both beta-1 and beta-2 receptors. And that's why many times we will, or most of the time, or all the time, if a patient has asthma, we tend to avoid non-selective beta blockers because we don't want to block beta-2. Again, if I was to ask you the question right now, if we have an agonist at beta-2 in an asthmatic or COPDer, what does it do to the bronchioles? It opens them up, right? Opens them up. So we can use it in that regard. If we block it, we run the risk of closing them, right, or causing constriction. So it's a contraindication to use a non-selective beta blocker. Now, some will say avoid cardioselectives. I would say maybe trial and error. It depends on the situation, especially in the CHFer, because you do have a mortality benefit. But the non-selectives I would avoid. With COPD, that's a little bit different mechanism. I think you can, and many times, get away with it, but proceed with caution for the same reason we just discussed, and go with the cardioselective. There's really no reason to use a non-selective unless you're using something like propranolol, like I use it for stage fright or something along those lines. But your cardioselectives, they're going to be specific for the beta-1 receptors. Now, as your doses get higher, you do start to lose selectivity. So that's why I say proceed with caution if you started in someone, especially with asthma. If you think you need the beta blocker and they have asthma, on a test, you're going to answer the question that the beta blocker is contraindicated. But in practice, you all know there's going to be opportunities to risk-benefit assessment where, okay, this is a CHF, I think this may benefit them. Could we start metoprolol at a 12.5 milligram per day dose and see what happens? You could possibly do that. It may be where you started in the setting of the hospital. Again, the asthmatic, you're going to be more cautious. Again, if you do, it's got to be a cardioselective. just know as you increase the dose, you do lose selectivity. You're not going to get a lot of innervation. It's not going to be therapeutic innervation, but it could be enough to exacerbate an asthma attack. The COPD, you can probably get away with it. But again, you want to proceed with caution. So our beta blockers, so these have efficacy in the treatment of hypertension. Usually not a first line, unless there's an indication, compelling indication, and that's going to be patients who have ischemic heart disease. Beta blockers and ischemic heart disease are always going to be the drug of choice. Beta blockers, after someone has had a myocardial infarction, they've had a heart attack, you're going to want to have them on a beta blocker. You can have cardiomyopathies after an ischemic event. Certainly congestive heart failure, again, it's one of the 4 pillars. This is something that has shown to prevent ventricular remodeling, and you want to make sure that the patient is on a beta blocker, specifically a drug called carbidiol Correg, which is an alpha beta mix, or a drug called metoprolol, specifically the succinate salt. And then certain arrhythmias. Now remember, when we get in our discussion about arrhythmias, we're going to talk about 2 flavors. We're going to talk about rate control and rhythm control. Beta blockers are going to be more of your rhythm. Your rate control. And then the antiarrhythmics will be more rhythmic control. But beta blockers they're one of the groups. You'll have your class 1, 2, 3, and 4 antiarrhythmics. Your beta blockers are going to fall into class 2. Class 1 is sodium channel blockers. Class 2 is your beta blockers. Class 3, your potassium channel blockers. That would be drugs like amiodarone or cortisone. And then your class 4 are calcium channel blockers, which we're going to talk about all that at a future date. But that's what we use them for. So our non-specific beta blockers, remember, they have effects on the heart and the cardiovascular system. So beta 1 receptors, right, on the heart, and beta 2 receptors in the periphery, more specifically the lung, right, the bronchi. And then beta 1 blockers, they're going to have more antagonistic effects of actions on the sands in the heart and blood vessels than on the lungs. So keep that in mind. And that's, again, why we try to avoid beta 2 blockers or non-specific, non-selective in people with asthma. So, but the beta 1, that's typically what you're going to use in your practice and go with. So propranolol, that's going to be your prototype of your to which most are compared. Propranolol is a non-selective beta adrenergic receptor antagonist. It's early in the morning for me. Equal affinity for beta 1 and beta 2 receptors in terms of blocking, so it does have more side effects. What dose do I take? If I do take it before, I don't take it often, but I usually do 20 to 40 milligrams times 1 dose, and I don't have any kind of problems for the most part. Your selective, probably if you had to have a prototypical drug, it's going to be metoprolol. So again, metoprolol comes in 2 flavors. There's a Toprol XL, right, that you can take once daily. You will see Toprol XL used twice daily, some, and you all may do that. It just depends on the situation, but you can see doses up to 150, 200 milligrams per day. But Toprol XL, what you need to know is metoprolol succinate. That's the succinate salt, and it's typically once daily. And then the metoprolol tartrate is a drug called Lopressor, and it actually comes in an IV form that we can use, give 5 milligrams to slow down. That's when we use that from an arrhythmia perspective for rate control. Remember, beta blockers are going to be more rate control. The antiarrhythmics will be more rhythm control. But the metoprolol tartrate, or brand name Lopressor, that's a twice daily drug. So those are the biggest difference. Now, why do we use the Toprol XL or the succinate salt for congestive heart failure? Very simple. That's what was utilized in the studies. I think Toprol XL may be generic now, and it's not a price issue, but back when it was branded and more expensive than the generic metoprolol tartrate, we would actually use twice daily metoprolol tartrate in our CHF, or you'd get the same benefit. It just wasn't quote unquote studied. But the other non-selectives, atenolol, you don't see much anymore. The brand name's Tenormin. Then you have ace-butylol, bisoprolol, and esmolol. Esmolol is used more for blood pressure IV control. You don't see these as much. Your workhorse is going to be your metoprolol. That's probably the prototypical beta 1 selective, and your non-selective is propranolol. But the beta 1 selective antagonist, remember, selectivity is not absolute. And especially as you push doses, And a normal dose of metoprolol, succinate, you'll see now for CHF, anytime you use any of the drugs for CHF, you don't dose them to effect, you dose them to the doses that were used in the studies. You try to get the patient to the dose used in the study if they tolerate it. Blood pressure, that may vary. I may need 25 milligrams of metoprolol. You may need 200 and three other drugs. That just varies. But when it comes to CHF, your dosing is very specific, and you do try to get the patient to the dose that was described. And you're going to have a handout when we get to these lectures towards the end of the semester that appreciates that and discusses all that and actually tells you how to do it and get them there. So that's what you want to do. But remember, selectivity is not absolute. That's why when we say, could you use a beta 1 selective antagonist in an asthma patient, on a test question, you need to put no, you could not. But in real life, there may be times where that opportunity may present itself. The benefit may exceed the risk. Those are going to be determinants that you're going to have to make in practice. Those are going to have to be situations that's why with medications, it's not just a one size fit all. You need to look at everybody's individual. What is best for this person? If I am absolutely healthy and I have high blood pressure, all I need is hydrochlorothiazide. I don't need an ACE or a calcium channel blocker like amlodipine, which is simply going to cause my ankles to swell or whatever. Constipation. Just keep it simple. Remember, Occam's razor, the simplest solution is probably the answer. But I show up to you and I'm 53 years old, I have high blood pressure and I have diabetes. Boom, 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 ACE or an ARB, because you know that's going to give me some renal protection for my diabetes. So you're going to pick the drug that's best for the patient. So make that individual assessment. It's very easy in medicine, especially with artificial intelligence and guidelines and cookbooking. We're kind of getting driven down a road where there's something else is making decisions for us. Don't ever lose your autonomy, okay? Please don't ever lose your autonomy. It's okay to use all the extra. Use your pharmacists, use your nurses, use your doctors you work with. Use them. Use all the artificial intelligence that's going to play a huge role in your career. It's not so much as mine, but yours. Use those, but at the same time, appreciate your autonomy to make the final decision on what's best for that individual that is sitting in front of you at that moment. Okay, that's a very, very, very special relationship, and you all get to be a part of it. Okay, so beta blockers, here's an interesting one. So partial agonist activity, this never really kicked off. This is what we call drugs or beta blockers that had intrinsic sympathomimetic activity. Wait a minute, Greg, so they were an antagonist and an agonist? Yeah, and your two prototypical drugs would have been Pendolol and H-Butylog. The UPS man is here. If my dog barks, please forgive me. But what they do is they actually partially activate beta receptors. So we call this ISA. This would be a good test question. So we call this intrinsic sympathomimetic activity. So as you know, when you block beta 1 receptors on the heart, it slows your heart rate, right? You get that negative chronotropic effect. Yeah, the doorbell's about to ring. I apologize. So this may, reason we do it, if a patient could not tolerate a beta blocker because of bradycardia, we could give a beta blocker with this intrinsic sympathomimetic activity to prevent the bradycardia. So, or the negative entropy in the resting heart. So what was the clinical advantage? It was really unclear, and we thought that it could be maybe a disadvantage when we talk about secondary prevention of myocardial infarction. Now, remember what I told you, if you've had a heart attack, you're going to go home on a beta blocker. And these weren't necessarily, we weren't seeing the benefits. So rarely, if ever used. Again, have I seen these before? I have. I know I have, but can I picture them in the last 20 years? I'm going on now year 29, we're 2024, 29 years, guys. I've been out of school for 29 years. And I've been married for 29 years. Wow, I just realized. We're kicking on January 4th, by the way, as I record this lecture. But yeah, we rarely or never use these. But I think you do need to know this, even if you don't see it on like the PANCE, your national certification exams. I think for your knowledge base to be complete, you need to understand that they're out there. And then we talked about the ones that have the mixed block of the alpha 1 and beta receptors. This is going to be labetalol. Labetalol comes in a tablet, and labetalol comes as IV. I like this one. So you'll see labetalol giving. I like labetalol in the ED We use it in pregnant women a lot who are having some issues with blood pressure, some eclampsia, preeclampsia, in addition to magnesium and other interventions that we do. But I like it because we can give it IV push. You'll see it given as a continuous infusion sometimes, but it really has its half-life is 15, 20 minutes. So it's not really a friend of titration. I think some of the calcium channel blockers, clovetapine or nicardipine, which we'll talk about at a later date, give you an option. Now, the carvedilol, this is Coreg, this is Trandate, the labetalol. The carvedilol is oral. This is more specific for congestive heart failure. Now, another reason I like these, if you have someone who comes in with a cocaine overdose and they have high blood pressure, if you give a pure beta, so if you have alpha and beta, right, and their blood pressure's high, if you give a pure beta blocker, you're going to block beta, but you have unopposed alpha, and that's where cocaine and methamphetamine are doing a lot of work. So while you're trying to lower the blood pressure, you can actually shoot it sky high. What I like about labetalol is you can use labetalol, the IV push, in someone who has a cocaine overdose or a methamphetamine overdose. It's gonna work pretty good for you. But just know that these two medications here, they are mixed. They're going to block alpha 1, and you know what that does when you block alpha 1, and they're also going to block beta adrenergic receptors. And carvedilol, though, again, is CHF. The labetalol we use for blood pressure, and it's very good in the hospital for acute use. I wouldn't use it, probably not. I don't know how much you see it. I never really see a lot on home med list. Remember, I work all in a hospital, but we do review a home med list. I don't see it much, but I see it quite a bit in the hospital. So it's an excellent drug to use. Your non-selective beta blockers, so on the heart, they're going to do the same thing. It's going to decrease cardiac output because you're slowing the pulse, right? So just by default, less beats per minute, less cardiac output. And you're also going to get a negative inotropic effect because you're blocking beta receptors. So you're going to get a negative chronotropic with the pulse and the strength of contraction, negative inotropic. Now you think, well, how's that helpful for congestive heart failure? Well, you have an overstimulation of the sympathetic nervous system already. Let's say you're just getting 2 impulses in the normal person. Well, the CHF, or it's fight or flight, the body's not perfusing. So it's going to be, remember, that constant bombardment. This is why a lot of our amphetamine patients that come in, and I'm talking young, 25, 30, they have ejection fractions of less than 30%. It's because they're totally bombarding their heart with a stimulant. And it's not the sympathetic nervous system, it's the drug that's causing it. Remember, it's going to be an indirect. It's going to increase, but the end game is norepinephrine bombarding it. So maybe we can block one of these by giving a dose of a beta blocker, and that's where titrating to the dose in the study comes into effect. We talked about in the lungs. So those who have asthma or COPD, specifically asthma, you'd want to avoid. But those who have COPD, it can induce an acute exacerbation of chronic obstructive pulmonary disease or an asthma attack. So you need to be appreciative of those who have pulmonary diseases, whether it's COPD or asthma. You need to understand that on a test, it's going to be beta blockers are contraindicated in patients with asthma and should be avoided in patients with COPD, although we do know that selective beta blockers in COPDers are tolerated. But if it's an asthmatic, for sure, if you get that question for a test, especially the PANTS, just go ahead and call it. You can't do it, but appreciate the fact that there might be a time when you have to do it in your practice. That's going to be a risk-benefit assessment of that particular patient. The asthma one's the one that really gives me concern. COPDers with the selectives tend to do well. So your non-selective beta blockers for the action. Diabetes, the beta blockade leads to decreased glycogenolysis and decreased glucagon secretion. So you can have some effects on your blood sugar. So hypoglycemia may occur after an insulin injection or taking a sulfonylurea. Now remember, most of our anti-diabetic drugs now don't cause hypoglycemia in and of themselves. Sulfonylureas would, we rarely use them. It used to be the workhorse before we had all the other drugs. You take a sulfonylurea, in essence, those type drugs, and we're going to talk about them. They just tell your pancreas to make insulin. And regardless of meals, it's like you take it, you're making it. So if you don't eat, you're going to have a risk of hypoglycemia anyway. But you can also take beta blockers to attenuate the normal physiological response, or beta blockers can attenuate the normal physiological response of hypoglycemia. Remember, fight or flight when your blood sugar starts to drop, your body goes into survival mode. Now, remember what I told you all, when my blood sugar gets around 70, I become tachycardic. And that's how I know. When it gets around 60, I get really hungry. Well, if I take a beta blocker, there's a chance that that first sign that my body gives me that something's wrong with my blood sugar, I've now blocked it. I've blunted it. So I might not know. And then you get, fight or flight, you get the sweaty hands, you get the thick, mucousy mouth, and you can block all that and you may not get it. And you may miss what some people will perceive as a sign or symptom of hypoglycemia without even testing their blood sugar. So therapeutically speaking, we talked about this. It's going to be hypertension. We certainly use them for angina pectoris, so ischemic heart disease or stable angina. You're going to have someone on a beta blocker. Myocardial infarction, we use it for survival benefit. They're going to go home on it. You will see propranolol used for migraines. And hypothyroid, that's more if someone is in a thyroid storm. All we're doing is trying to slow the heart rate and protect the heart temporarily. You're going to do other interventions to make the hyperthyroid euthyroid. In some cases, we have to go over and we go from hyper to hypo. And as you all know, and we'll talk about that when we talk about endocrine type stuff. And the pituitary gland, the master gland, we'll talk about all that in the hypothalamus at a later date. So the adverse effects, we've discussed the bronchoconstriction. We know about the contraindications, the arrhythmias, beta blockers. If they're stopped abruptly, it can precipitate arrhythmias. And why is this? This is due to upregulation of beta receptors. You see this phenomenon a lot. This is what causes alcohol withdrawal and various withdrawals, but your body tries to be protective. So let's say in the normal person, you have two receptors and you block one of them. Your body doesn't like that. So your body's going to come back and going to make two more. Well, you're titrating your dose and you get it where you're blocking it. You have it where you want. Okay. So you went from 2 to 4 receptors, but you're blocking 3. So you're still at your net of just one active, if that makes sense. Well, what happens if you just cold turkey stop taking all this? Well, instead of having 2 receptors that aren't blocked anymore, because you decided not to take your drug anymore, now you got 4. And so what's hitting all this? Now you got 4 adrenergic receptors being innervated and stimulated instead of 2. And that's the problem. Really, the only times you'll temporarily hold them is if a patient is in decompensated heart failure. When a patient comes into the hospital and you need to do surgery and they're NPO, meaning they can't take the oral meds, we do have protocols for IV beta blockers. There's been some recent studies that have questioned, do you really need to do that or not? Is there more harm than good? I don't know. So if you go to hospitals and they're doing that, you can see maybe they're getting away with it. I do not see this at my hospital. Not sure why. Haven't looked into it. But again, saying that when I say that, usually most people are back on their beta blockers sooner than later. Maybe it's something I need to be more cognitive of, because you do have the patients that will have a prolonged NPO, usually abdominal surgeries, but you get your knee fixed or something like that, you're going to be able to take your meds. But if someone has some reason, in most abdominal surgeries we have, the surgeons have really good techniques of getting patients at least back on their medications. They might not be able to eat a meal, they might be NPO except meds, but we're pretty good at getting patients back on their medications sooner than later, as we were in previous days. So that's something to keep in mind too. But that's the reason you get an upregulation of beta receptors. Same thing happens in alcohol withdrawal. You get increased glutamate because you're doing all this suppression with GABA. So your body's just trying to stay even. And then you just stop drinking the alcohol, the depressant, you have this extra glutamate. And what do you get? Well, you get within 24 to 48 hours, you start having withdrawal, which can be stimulation, which can be up to seizures, death, and coma. Adverse effects, the metabolic disturbances, we talked about it. You're going to have decreased glycogenolysis and glucagon secretion. So fasting hypoglycemia may occur. Need to be appreciative of that. Again, the beta blockers can prevent the counter-regulatory effects of catecholamines during hypoglycemia. We talked about that. Mine is the tachycardia and the nervousness that I get. I don't really get a tremor. I take that back. My hands will get shaky. We were doing a lecture the other day. I was worried if I was my blood sugar went low while we were in here, and it was around 70. I say low, it wasn't low at 70. But my hand, when I would point, sometimes I'm pointing at the screen when we're talking, real animated, even when I'm doing it in my office here by myself. I'm pretending like you all are in front of me. But anyway, non-selective beta blockers also can increase triglycerides and reduce high-density lipoproteins. I don't know if that's really of clinical relevance, though. There's going to be a lot of other things going on with these patients where they're going to have that situation anyway. Your selective beta blockers, here's your classic drugs. Your prototypical drug is going to be metoprolol. These are void, or you mitigate some of the side effects that you see with the non-selectives, like the lipid profile, CNS effects, pulmonary. Again, therapeutically speaking, it's going to be hypertension, chronic stable angina or post-myocardial infarction, cardiomyopathies, and chronic heart failure, which we've discussed. So I think that's it. So that is going to, that will be the official, that's the official last lecture for test 1. And I'm going to share the screen because I want you to see this, and you're going to see this before you even get there because I can't find it. I'm going to share my desktop with you. If you see text messages pop up that are someone's trying to be funny, don't take it out on me, please. You know, there's 10,000 comedians that are out of work in this world. I got 900,000 friends that are pharmacists that are comedians. So here we are. We're going to make a change. That week 5, week 5, we're going to jump into genital urinary. Things are going to start going very, very quick. So week 4, and I'm doing this so I can update my sheet, how we're doing. We used to do this in class, and the lectures were a little bit longer. So ANS is done. So here's what you have, what you're going to go through. You're going to see your syllabus and all that, but we're going to go through all this. Please read the handouts and the chapters, but all the way through the autonomic nervous system. So it's going to be through all the week 4 lectures, and I think we said we're going to call this one 1.5. Starting at week 5, we're going to do genital urinary and urologic. We're going to fly through these pretty quick, and we'll catch up. The psychotherapeutics, we're probably going to go into those sooner than later. Depends how it's set up, but if don't, I'll let you know as we go, and then certainly we'll go into exam 2. But exam 1 will be, hopefully when you watch this, we've already had detailed discussions about exam 1, and we've had a few live times, a couple of 2-hour sessions where you all have the opportunity to come on Zoom at your convenience over a 2-hour time period to discuss any questions you have in the live situations. Okay, that's where we're at. Best of luck on exam 1. If you're having concerns of anything that we just discussed, I'm here. Reach out to me. I'll make the time for you. Okay. So it's in your hands. I'm here for you. I'm your instructor. But at the same time, I'm going to be your biggest fan. So let's do this. Let's do this. So good job so far, and we'll see you soon.